I still have my book, Pathways. Take a look. Look at my look at my notes from 23, 24 years ago. These are all my notes. RC prep. Look at this. All my notes. Okay, Pathways of the Pulp. You need to know this book. You need to know this book. It's a pretty thick book, but you need to know this book from cover to cover. Memorize it. All right, so if you look under C nerve fibers, page 33 of my book here, take a look here. When inflammation leads to pulpal necrosis, a periodicular lesion may develop as an extension of the pulp pathology. Even when a radiographic lesion is clearly visible, some nerve fibers may respond to vitality testing. Both myelinated and unmyelinated nerves have been found in teeth with necrotic pulps and periapical lesions. Both myelinated and unmyelinated nerves have been found in teeth with necrotic pulps and a periapical lesion. For this reason, instrumentation of teeth with necrotic pulps may cause pain. Right here. Guys, when a patient comes to you and they complain of a what? Of a dull and poorly localized pain associated with their tooth. Okay, that's a C nerve fiber that's being activated. Okay, a C nerve fiber usually gets activated near the end of the irreversible pulpitis stage, which means that this tooth has gone through the irreversible pulpitis and is near the end of the irreversible pulpitis and is going towards necrosis, pulpal necrosis. Okay? See? In most cases, it occurs later as a secondary pain. C fibers have a high threshold and can be activated by intense heating or cooling of the tooth. Alright? So patient complains of heat sensitivity. That means that the C fiber has already been activated, which means you're near the end of the irreversible pulpitis stage. This tooth is now going towards necrosis. And then you say, I had an argument with a general dentist, and she was saying that in cases like this, she just does occlusal adjustment, and the patient doesn't need a root canal. See, when you don't know the science, and you make stuff up, it's just really embarrassing. Know your science. So the reason you do occlusal adjustment, you take the tooth out of occlusion pretty much, and then patient gets relief. Do you know why that is? That's because this patient has already, as I said, gone through irreversible pulpitis. It's towards the pulp is going towards necrosis. There's also Periapical changes. Inflammation has gone from the pulpal to periapical area. So there's inflammation of the periapical region. So this tooth is super occluded. So when you take it out of occlusion, you do occlusal adjustment. Of course, this patient is the tooth is gonna feel better because by then the pulp has necrosed too. So that's why your patients feel better, because now you got a necrotic pulp. But that doesn't mean the occlusal adjustment worked. So patient leaves your office with an occlusal adjustment, and you think that your treatment worked. And later on, when the tooth blows up on this patient, it's very likely that they probably won't come to you. They go somewhere else for emergency treatment because chances are that they don't trust you anymore. And then you think that your treatment worked, your occlusal adjustment worked. So this is called anecdotal science or experiment, science, or no, not science, just anecdotal. And based on your personal experience, it's not rooted in science. So if you don't know your science, you're going to be in trouble and your patients will be in trouble. Today's episode on reading from Pathways of the Pulp. If you do endo or if you're a dentist, you need to know this book pretty much by heart. So I get a lot of messages from my followers. They're dentists. They send me a couple of x-rays and say, what do I do with this? Does this tooth need a root canal? They want me to look at a couple of x-rays and then tell them if the tooth needs a root canal. Doc, what is happening? Do your examination. Or if you're sending me x-rays, okay, x-rays are fine, but send me the rest. Tell me what's going on. Give me the medical history. Give me the results of the test that you've done. You need to have done examination and testing. Page 7 of Pathways. Extraoral examination. Intraoral examination. If there are sinus tracts, swellings needs to be noted. Sinus tracts needs to be traced. Palpation test. Percussion test. Tenderness noted upon percussion or percussing a tooth indicates some degree of inflammation in the periodontal ligament. Percussion test by itself doesn't mean a tooth needs a root canal. It's just a test that you do. Inflammation in the periodontal ligament may be caused by occlusion, trauma, sinusitis, periodontal disease, or extension of pulpal disease into the periodontal ligament. Percussion is not a test of pulp vitality. Thermal tests combined with electric pulp testing that evaluate pulpal nerve function are required to establish pulp vitality. Okay. Mobility. Test for the mobility of the tooth. Periodontal examination. What do I always tell you? You have to do periodontal examination of the tooth. What does that mean? You need to probe the tooth. Probe it. Then you do thermal pulp tests, which is usually cold test. Then the cold test will tell you the status of the pulp. I used to do heat test. I don't do it anymore. Electric pulp test. I used to do it. I don't do it anymore. But these are the things that you need to know. You need to know all of this stuff. Then you look at the multiple angulation radiographs, radiographic examination. And I talk about that, multiple angulation PAs. And then you need to, of course, be able to read x-rays and interpret x-rays. Radiographic interpretation. All right? So don't just send me a couple of x-rays and tell me, hey, doc, what do you think? Does this tooth need a root canal? Read this book. These notes are mine, my handwriting. I took these notes when I was reading Pathways 20-some years ago. Look at that. MTA. What's in MTA? Tricalcium silicate, tricalcium oxide, and all that stuff. Because of high pH, hard tissue formation occurs after use as a retrograde filling, not adversely affected by blood contamination. MTA in contact with periradicular tissue forms a fibrous connective tissue and cementum, causing only low level of inflammation. Oh, my notes. Look at that. Check this out. Notes from 25 years ago. RC prep sequence. Straight line access. If vital pulp and bleeding, filled chamber brimful with a viscous chelator like RC prep. When pulp is necrotic, irrigate and fill chamber with 5.25% warm sodium hypochlorite. Use smaller stainless steel files. Pre-curve to full length. Stainless steel O2 tapered number 10 and 15 hand files are used to scout coronal 2/3. 25 years ago, my notes. After scouting coronal 2/3, canal flushed with sodium hypochlorite and pre-enlarged using hand or rotary files. With coronal 2/3 optimally prepared and filled with irrigant, apical 1/3 is scouted and information gathered. You always scout, remember? I always tell you that. Working length is confirmed using X-ray apex locator or apex locator. If you don't have apex locator, you go with X-ray, or sometimes you do both. With root canal negotiated anatomy fully appreciated, a decision can be made whether to finish apical 1/3 with hand files or rotary. Aqueous 17% EDTA flooded into well-shaped prep for 1 minute has been shown to remove and eliminate smear layer. I used to do that. I don't do it anymore because back then we didn't have sonic and ultrasonic activation, but now we do, so I skipped this part. In 1847, Hill developed the first GP-RC root canal filling material called Hill's Stopping. To remove smear layer, wash canal with a chelating agent such as EDTA, 17% EDTA or 10% citric acid, and then thoroughly rinse canal with 3 to 5% sodium hypochlorite to remove moisture from canal, either 95% ethylene alcohol or 99% isopropyl alcohol left in canal for 2 to 3 minutes. See, these are the fundamentals that I always talk about. I say follow the fundamentals, rubber dam, all of that. These are all the fundamentals. You can see that in 25 years, these fundamentals have not changed. We've added, modified the root canal procedure, okay, but the fundamentals stayed the same. Today's episode of Reading from the Bible, and I've covered this topic many times. Question is often asked in cases of a patient walking in as an emergency. They have a hot tooth, irreversible pulpitis. You diagnose the tooth as irreversible pulpitis, but you don't have time. What do you do in these situations, in these cases? And I always say, do a pulpectomy. Or if you don't have time to do a pulpectomy, don't put a file in the canal unless you commit yourself to do a pulpectomy. Okay, you can do a pulpotomy, but that could relieve some of the patient's symptoms, but not all. But the best ideal thing to do would be to do a complete pulpectomy, and here's why. And again, I've covered this case many times. I've read this book maybe 10 times from cover to cover. So I know what's going on, and that when I give you guys my recommendation, my advice is based on science. It's not based on my anecdotal experience. So here we go. Irreversible pulpitis. Emergency management for painful irreversible pulpitis involves initiating root canal treatment to alleviate the pain, okay? Irreversible pulpitis can be predictably managed by complete removal of the pulp and total and cleaning shaping of the root canal system. In multi-rooted teeth, a pulpotomy, that is the removal of the coronal pulp, or partial pulpectomy, that is the removal of the pulp from the widest canal, have been advocated for emergency treatment of irreversible pulp. However, because it is impossible to detect clinically the apical extent of the inflamed pulp and therefore provide predictable pain relief, it is important to perform a pulpectomy at the emergency visit. Good morning. A file should not be introduced into any canal unless a pulpectomy is anticipated. Often inflamed vital pulp tissue that is lacerated with endodontic files will result in increased discomfort. So patient comes into your office with a lot of pain. You don't do a full pulpectomy. You just put a file in the canals. Patient leaves with more. So don't put a file in a canal, into any canal, unless a pulpectomy. You commit yourself to a full pulpectomy. Okay? So often inflamed vital pulp tissue that is lacerated with endodontic files will result in increased discomfort because the pulp has become inflamed, shredded, and traumatized. Pain symptoms can persist or worsen if inflamed pulp remains in the root canals, because the inflammatory process will extend into the periodical tissues. Okay? So, don't put a file into a canal unless you do a full pulpectomy. And now check this out. Post-operative pain and the long-term prognosis after single visit endodontics is similar to root canal treatment completed in multiple visits. So, to those who say, patient comes in
and they're in a lot of pain, it's recommended that we do it in multiple visits. Do the root canal multiple visits because of the fact that the patient comes in with pain? No, that's not the case. So, no contraindication to single visit endodontic treatment. Post-operative pain and the long-term prognosis after single visit endodontic is similar to multiple visits. Because temporary restorations eventually leak, obturation in one visit eliminates the possibility of inter-appointment bacterial contamination of the root canal system. Okay, so if you run out of time, if you don't have time, yes. However, time constraints at the emergency visit often make the single visit treatment option difficult. So if you don't have time, then you can do it in 2 visits. But ideally, you want to do obturate in 1 appointment. If I told you that this book alone probably has saved more lives than the Torah, the Bible, and the Quran combined. All right, let's read. Okay, so today I want to talk to you about the periapical disease. All right, this is how we learned it. I know the nomenclature has changed, but this is what I'm comfortable with. I still use this nomenclature. All right, so periapical disease. We have acute apical periodontitis, acute periradicular abscess or acute apical abscess. We have chronic apical periodontitis, chronic apical periodontitis. We have phoenix abscess, and we have periapical osteosclerosis. All right. So acute apical periodontitis, just to simplify, is when you percuss a tooth and it's tender to percussion. That's what this means. This is the periapical status of the tooth, not the pulpal status of the tooth. It could be related to the pulpal status of the tooth, but sometimes it's not. Sometimes a healthy pulp tissue, a tooth with a healthy pulp tissue can exhibit acute apical periodontitis. Why? Well, acute apical periodontitis is painful inflammation around the apex of the tooth. This condition can be the result of an extension of pulpal inflammation. So it could be the result of pulpal inflammation, extension of it into the periapical tissue. It could be mechanical or chemical trauma by endodontic instruments or materials, or occlusal trauma caused by hyperocclusion or bruxism. Because acute apical periodontitis may occur around vital and non-vital teeth, conducting a thermal pulp test is the only way to confirm the need for endodontic treatment. As always, the need for endodontic treatment must be determined by pulpal status alone. Just because a tooth is tender to percussion doesn't mean you'll need a root canal. That's what it means. In today's episode of Reading from Pathways of the Pulp, let's talk about acute periodicular abscess or acute apical abscess, AAA. All right, so what is it? An acute periodicular or acute apical abscess consists of a painful periodontal exudate or abscess around the apex. This abscess is the result of the exacerbation of acute apical periodontitis from an infected necrotic pulp. Although this disease can be very serious, the periodontal ligament may appear within normal limits, or it may be only slightly thickened. This is because the rapid progress acute in the temporal sense of the infection has spread beyond the confines of the cortical plate before the mineralization can be detected radiographically. Thus, the periapical radiograph may only reveal a relatively normal or a slightly thickened lamina dura. So, a patient, basically what it says is that a patient walks into your office, their face is all swollen up. You take some PAs, you don't see a periapical radiolucency associated with any of the suspected teeth. But the patient's face is all swollen up. No periapical radiolucency, but the patient's face swollen up. That is acute periradicular abscess or acute apical abscess. The abscess has developed so fast that there hasn't been enough destruction of the periapical region of the tooth to give you that periapical radiolucency. The only way really to figure out which tooth is the problem here, which tooth is the source of the problem, is pulp vitality testing. Okay, so you pulp test the teeth in the area. The tooth that doesn't respond to your vitality test is the necrotic tooth that is the source of this acute apical abscess or acute periradicular abscess. The signs and symptoms of acute periradicular abscess include rapid onset of slight to severe swelling, moderate to severe pain, pain from percussion and palpation, and the possibility of a slight increase in tooth mobility. Now, really, the only difference between acute periradicular abscess or acute apical abscess and a phoenix abscess is that with the phoenix abscess, you do have a periapical radiolucency on your PA. You do see a periapical radiolucency on your PA. In acute apical abscess, acute periradicular abscess, you don't. That's the only difference between these two. Phoenix abscess, you see a periapical radiolucency on your PA. Acute periradicular or acute apical abscess, you do not. In today's episode of Reading from the Holy Book of Endodontics, I would like to cover the periapical osteosclerosis. What is that? Periapical osteosclerosis is excessive bone mineralization around the apex of an asymptomatic vital tooth. This radiolucency may be caused by low-grade pulp irritation. Because this condition is asymptomatic and benign, it does not require endodontic therapy. And this is a picture of it. As you can see, this area right here. Now, you read this, right? I read this for you. Tell me what's going on. What's wrong with this paragraph? In today's episode of Reading from the Holy Book of Endodontics, let's talk about tooth isolation, principles and rationale. The use of the rubber dam is mandatory. The first sentence, the use of the rubber dam is mandatory. It doesn't say the use of the rubber dam is optional. It says the use of the rubber dam is mandatory in root canal treatment. Developed in the 19th century by S.C. Barnum. The rubber dam has evolved from a system that was designed to isolate teeth for placement of gold foils to one of sophistication for the ultimate protection of both patient and client. The advantages and absolute necessity of the rubber dam must always take precedence over convenience and expediency. And then he also mentions a rationale often cited by clinicians who condemn its use. So some clinicians, they don't use it because they say it's not convenient and it slows me down. So the book says it's absolutely necessary, it's mandatory, get over it, you have to use it. When properly placed, the rubber dam facilitates treatment by isolating the tooth from obstacles such as saliva and tongue. They can disrupt any procedure. Proper rubber dam placement can be done quickly and will enhance the entire procedure. So no excuses. The rubber dam is used in endodontics because it ensures the following. Patient is protected from aspiration or from the swallowing of instruments, tooth debris, medicaments, and irrigation solutions. Clinician is protected from litigation, which means lawsuits. If you don't use a rubber dam, clinician is protected from litigation because of patient aspiration or swallowing of an endodontic file. Remember the case I presented? The dentist didn't use a rubber dam and the patient inhaled a file, went into his lung. Remember that case? Routine placement of the rubber dam is considered the standard of care. This is the legal term for using the rubber dam. Not only mandatory, okay, not only absolutely necessary, but also routine placement of the rubber dam is considered the standard of care. Using sodium hypochlorite is not considered the standard of care. But rubber dam placement is considered the standard of care. You see how important the rubber dam is? I mean, this book can't emphasize how important this rubber dam placement of the rubber dam is. I mean, mandatory, a must, standard of care, no excuses. A surgically clean operating field is isolated from saliva, hemorrhage, and other tissue fluids. The dam reduces the risk of cross-contamination of the root canal system, and it provides an excellent barrier to the potential spread of infectious agents. It is a required component of any infection control program. Required component. Soft tissues are retracted and protected. Visibility is improved. The rubber dam provides a dry field and reduces mirror fogging. Efficiency is increased. The rubber dam minimizes patient conversation during treatment and the need for frequent rinsing. It also relaxes the patient and saves time. In today's episode of Reading from the Holy Book of Endodontics, One Appointment Endodontics. The popularity of single visit treatment can be credited to favorable reports that found no difference in treatment complications or success rates when compared with teeth treated in multiple visits. And here are the references: 48, 142, 150, 209. 48. Eliezer, PD, Eliezer, KR. Journal of Endodontics. 142. 142. 142. Pecron RB, the incidence of failure following single visit endodontic therapy, Journal of Endodontics. All right, next one. 150. 150, Rowan, JB, Dryden, JA, Grimes, EW. Incidence of postoperative pain after single visit and multiple visit endodontic procedures. Oral surgery, oral medicine, oral pathology. And the next one was 209. 209. Walton, R.E., FOD A. In today's episode of reading from the Holy Book of Endodontics, let's talk about the dreaded hypochlorite accident. Hypochlorite accident. Accidental injection of sodium hypochlorite into the periapical tissues. Alright, so that's what it means. A hypochlorite accident refers to any event where sodium hypochlorite is expressed beyond the apex of a tooth and the patient immediately manifests some combination of the following symptoms: severe pain, even in the areas that were previously anesthetized for dental treatment, swelling, profuse bleeding, both through the tooth and outside. What are the causes? Well, some of the reasons that a hypochlorite accident may occur include forceful injection of the sodium hypochlorite, having an irrigating needle wedged into a root canal, not using a specific irrigating needle, using a regular needle. Irrigating needle, even if you use an irrigating needle, if you wedge it in, if it's wedged into a root canal, and then you forcefully inject the solution, you get a sodium hypochlorite accident. Okay. Now, how to manage it? Management. You must recognize immediately that there was a sodium hypochlorite accident. Okay. Immediate problem of pain and swelling should be attended to first. A regional block with a long-acting anesthetic solution, such as Marcaine, should be administered. With the irritant spreading rapidly over a wide range, pain management is difficult because symptoms from distant anatomic structures will continue to cause discomfort. This also explains the extreme pain felt during the incident, despite establishment of adequate local anesthesia before treatment. Calm the patient down. Monitor the tooth for the next 30 minutes. A bloody exudate may discharge back into the canal. This bleeding is the body's reaction to the hypo. To encourage further drainage from the periapical tissues, the fluid should be removed with a high volume evacuation. If drainage is persistent, the clinician should consider leaving the tooth open. You can leave the tooth open over the next 24 hours. The clinician should consider antibiotic coverage. The clinician should consider an analgesics, but avoid aspirin and NSAID because they can cause bleeding, so stick to acetaminophen narcotic combination. You can prescribe corticosteroids. Steroids will help minimize the ensuing inflammatory process. The patient should be given home care instructions. For the first 6 hours, the patient should use cold compresses and then warm compresses thereafter. The clinician should consider referring the patient Either refer the patient to an endodontist or an oral surgeon. Prevention. A hypochlorite accident is completely avoidable. As an endodontic irrigant, hypochlorite solution is meant to flush debris from the root canal system. Part of the efficacy of the hypochlorite depends on the volume of irrigation, as well as the depth of penetration of the irrigating needle. Even so, the solution must be delivered in a passive manner to avoid apical extrusion. As root canals are coronally flared during the cleansing and shaping process, the irrigating needle can penetrate deeper into the canal while still not binding against the walls. Okay, so the irrigating needle should be bent at the center to confine the tip of the needle to higher levels in the root canal and to facilitate direct access to all teeth, regardless of the angulation. The needle should never be placed so deeply into the canal that it binds against the walls. Look at these poor people. This is all hypo accident. The needle should be oscillated in and out of the canal to ensure that the tip is free to express irrigant without resistance. The irrigant should be expressed slowly and gently. Irrigation should be stopped if the needle jams or if there is any detectable resistance on pressing against the plunger of the syringe. The hub of the needle should be checked for a tight fit to prevent inadvertent separation, accidental exposure of the irrigant to the patient's eyes. Okay? In today's episode of Reading from the Holy Book of Endodontics, let's talk about management of abscesses and cellulitis. In other words, let's talk about when to prescribe antibiotics and when not to prescribe antibiotics. The prescription of antibiotics is not recommended for irreversible pulpitis. Is not recommended for irreversible pulpitis, acute apical periodontitis, a draining sinus tract, after endodontic surgery or after incision for drainage of a localized swelling. If there is no fever, there is no cellulitis, there is no lymphadenopathy, you don't prescribe antibiotics. The use of adjunctive antibiotics is recommended in conjunction with appropriate endodontic treatment for progressive or persistent infections or both, which have any of the following systematic signs and symptoms. These include fever, more than 100 degrees Fahrenheit, malaise, cellulitis, unexplained trismus, and progressive or persistent swelling or both. Other than that, there's no need for antibiotics. With these signs and symptoms, the prescription of an antibiotic is indicated as adjunctive therapy to effective debridement of the root canal system. Remember the case that I presented the other day? The clinician had put the patient on 250 milligrams of amoxicillin to be taken twice a day for 10 days. All right. Here you go. And I was so frustrated. I was so upset with this clinician. Here we go. I know this book by heart. All right, so here we go. A high dose regimen for a short time is preferred to a low dose for a longer time. The latter is much more likely to select for resistant organisms. Now, if you're prescribing amoxicillin, An oral loading dose of 1,000 milligrams of amoxicillin should be followed by 500 milligrams every 8 hours for 6 to 10 days. Now let's say you put a patient on penicillin, and if after 2 or 3 days of penicillin therapy, you don't see any improvement of the patient's signs and symptoms, then you can add metronidazole to the penicillin. Okay. After reviewing the diagnosis and appropriate drainage, the addition of metronidazole to penicillin is indicated. Metronidazole is prescribed in a loading dose of 500 milligrams, followed by 250 to 500 milligrams every 6 hours. Penicillin should be continued because metronidazole is not effective against facultative bacteria. Patient taking metronidazole should not consume alcohol during therapy and for at least 3 days afterward because disulfiram type of reaction. Likewise, metronidazole should be avoided in patients taking lithium. And of course, clindamycin is recommended for patients with a serious infection and an allergy to penicillin. Clindamycin should be prescribed with a 300 milligram loading dose and then 150 to 300 milligrams every 6 hours for 6 to 10 days. In today's episode of Reading from the Holy Book of Endodontics, let's talk about working short. Generations of dentists have been trained to work short of the radiographic terminus. The extent of shortness, although well-intentioned, has been arbitrary and based on misinformation, misconception, and myth. Every dentist who has worked short has experienced the frustration of apical blockage, ending up even shorter than was intended. A loss of working length occurs because of the combination of collagenous tissue apically or the accumulation of dentin. A loss of working length occurs because of the compaction of collagenous tissue apically or the accumulation of dentin mud or both. Apically blocked canals frequently hold combinations of pulp, bacteria, and their endotoxins, and dentin mud. In the instance of the lost foramen, many clinicians become frustrated and aggressively attack the obstacle, which serves to inadvertently compact debris apically. Therefore, significant numbers of root canals have residual tissue and byproducts left in their terminal extents. Leaving pulp remnants or necrotic debris in the avascular root canal system is one of the major factors in persistent attachment apparatus disease. Researchers, academicians, and clinicians are well aware that there is a discrepancy between the anatomic position of the foramen on the external root surface of the root apex observed radiographically. Traditional wisdom states that the canal terminates apically at the cemento-dentinal junction and that the working length should extend to this anatomic landmark. Histologically, the CDJ varies significantly from tooth to tooth, from root to root, and from wall to wall within each canal. It can never be located precisely by radiographs during clinical procedures. Electric apex locators, although still imperfect, and we're talking about this book is 20-some years old, now they're pretty good. they're actually very good, represent a significant improvement over radiographs because they more accurately identify the position of the foramen. Working arbitrarily short of the radiographic terminus based on statistical averages encourages the accumulation and retention of debris, which may result in apical blocks that predispose the patient to ledges and perforations. Working short has led to many frustrations, inter-appointment flare-ups, unexplained failures, surgical procedures, and even extractions. In today's episode of reading from the Holy Book of Endodontics, cleaning reagents. The most important one, number one, look, cleaning reagents, number one, sodium hypochlorite. So the use of sodium hypochlorite was introduced during the World War I by a physician named Dawkins, because antibiotics at the time were not discovered yet by Alexander Fleming. So they used to lavage, they literally used to wash large flesh wounds with Dawkins solution, which was basically sodium hypochlorite. And he saved Dawkins solution, sodium hypochlorite, lavaging, washing the flesh wounds during World War I, because there was no penicillin yet, saved many lives that may have been otherwise lost to gangrenous infection. Chlorix or Purix are the sources for obtaining full-strength 5.25% sodium hypochlorite. So you don't need to buy the dental company's sodium hypochlorite. They give you a little tiny bottle for like $20 or something. Just go to a grocery store and buy the regular sodium hypochlorite. Just make sure it's not scented. They haven't added anything to the solution. The frequency of irrigation is also very important. The recommended frequency of irrigation with 5.25% sodium hypochlorite is after each file. After each file usage, so you fill the canals and the pulp chamber, of course, with full strength, which is 5.25% sodium hypochlorite. Then you use one file, okay? Then you irrigate. Then you recapitulate. Then you irrigate again with full strength sodium hypochlorite, 5.25%. And then you go to the next file. Use a file, remove the file, irrigate with full strength sodium hypochlorite, then recapitulate, then irrigate again, then go to the next file. Now remember how much I emphasize the importance of having 4 intact walls of the pulp chamber before initiating endodontic treatment. Let's say tooth is decayed and 2 walls of the pulp chamber are missing. You clean out the decay. You must rebuild those missing walls. You must rebuild those missing walls, okay? And that's where I get this from. Regardless of the method of introduction of the sodium hypochlorite, it is essential to have a pulp chamber filled brimful with a reservoir of sodium hypochlorite to promote tissue dissolution, flushing out of debris, and 3-dimensional cleaning of the preparation. The hand that holds the irrigating syringe is always kept in motion when dispensing irrigant to prevent the needle from inadvertently wedging in the canal, slowly injecting air again in combination with continuous hand movement will virtually eliminate sodium hypochlorite accidents. It is important to irrigate frequently and voluminously to introduce fresh solution and potentiate its circulation into all aspects of the root canal system.
In today's episode of Reading from the Holy Book of Endodontics, yesterday we talked about the importance of using copious amounts of sodium hypochlorite during endodontic therapy. Today, I want to talk to you about chelating agents. And one of them, the most famous one, is the RC prep. So, when do we use chelating agents and what they are? What are chelating agents? Chelating agents contain EDTA and may be used clinically to eliminate many cleaning and shaping frustrations. The purpose of a chelator is for lubrication, emulsification, and holding debris in suspension. We have two types of chelating agents. One is a viscous suspension and the other one is an aqueous solution. Okay, so as an example, again, RC prep is one example of a viscous chelating agents. Again, the principal ingredient is EDTA, urea peroxide, and propylene glycol. When indicated, the pulp chamber is filled brimful with chelator. And here we're talking about a viscous suspension, such as RC prep. Then pre-curved files are gently inserted through the pulp chamber and carry chelator into the canal by surface tension. And here you can see the pulp chamber is filled brimful with RC prep. An example of a viscous chelator. The lubricant encourages the file to slip and slide by intracanal calcifications such as pulp stones or sheets of fibrous or fibrotic tissue. In tighter and more restrictive canals, chelators are very important to use during initial coronal enlargement because these suspensions emulsify tissue, soften dentin, minimize blockages, and hold debris in suspension where it can be subsequently aspirated from the preparation. A viscous suspension of a chelator advantageously promotes the emulsification of organic tissue and facilitates the negotiation of the canal. Collagen is a major constituent of a vital pulp tissue and can be inadvertently packed into a glue-like mass that contributes to iatrogenic blocks. In vital cases, attempting to negotiate any portion of a canal with a number 10 file without the aid of a chelator can be risky. When the instrument is withdrawn, the vital tissue tends to collapse and re-adhere to itself. A chelator discourages this tissue phenomenon and accelerates the emulsification by leaving a favorable pilot hole that facilitates the introduction of the sequentially larger instrument. Viscous suspensions of chelating containing reagents are important adjuncts to overcome pockets of resistance within a canal and to assist in the development of a smooth glide path to the terminus. Chelators
should be used for short periods because their protracted use can soften dentin and predispose the patient to iatrogenic mishaps. You see that? You see how important science is, knowing what you're doing, the science behind what you're doing, how important that is? This book will teach you all of that. There is science behind why we do what we do. If you don't know it, and just like an amale, you try to just mimic someone's doing something, then no wonder your cases are failures. You block yourself, you perforate, and so on and so forth. Know the science. Know why you do what you do. Now, an aqueous solution of a chelator, such as a straight up EDTA, like a liquid EDTA, what we use in endodontics, 17% EDTA. It's an aqueous solution. It is best reserved for finishing the preparation. It removes the smear layer that is an organic or inorganic film or both formed on the walls of the canal by the cutting action of instruments. In today's episode of reading from the Holy Book of Endodontics, one thing that I wanted to mention the other day and I forgot was when I was talking to you guys about sodium hypochlorite. Remember, sodium hypochlorite, the history of sodium hypochlorite, it was that it was introduced during World War I. And it saved perhaps millions of lives because they used sodium hypochlorite at the time there was no penicillin. Penicillin wasn't discovered yet. So they would lavage, they would actually wash large flesh wounds with sodium hypochlorite. So if during instrumentation and irrigation of a canal, some of your sodium hypochlorite goes outside of the canal and into the periapical area, that is not considered a hypoaccident. If during irrigation, instrumentation and irrigation, some of your sodium hypochlorite goes out the canal without any force or pressure, perhaps there will be a little bit of bleeding. You'll be seeing some bleeding from the canal. Patient does not experience any pain sensation or burning sensation or what have you. That is not a sodium hypochlorite accident. As a matter of fact, perhaps more than you know, some of your hypo does go to the outside of the canal, gets to the outside of the canal in the periapical area. You wouldn't even know it. So that's different from a hypoaccident. A hypoaccident is forceful injection of the sodium hypochlorite out the canal into the periapical area. Forceful. And then you're going to be seeing all kinds of consequences of the sodium hypochlorite accident, okay? So I just wanted to clarify that. So today I want to talk to you about canal preparation techniques. There are many ways to prepare a canal. There are many different instruments, different techniques. But the fundamentals of endodontics is unchanged. Instrumentation techniques and irrigation protocols, and those can change. But the fundamentals stay the same. The mechanical objectives for canal preparation can be fulfilled using a variety of instruments. I have many messages from my followers saying, hey, I use this kind of instrument, whatever file system. Is that okay? If it works for you, it's okay, as long as you follow the fundamentals of endodontic. The concepts for canal preparation endure. Basically what they're saying is that the fundamentals stay the same, fundamentals of endodontics, whereas the instruments, strategies, and techniques used for cleaning and shaping root canals constantly evolve. What are the fundamentals? The fundamentals of endodontics start with rubber dam. You place a rubber dam. Rubber dam is mandatory. We covered that, remember? Rubber dam is mandatory. No rubber dam, no root canal. You place the rubber dam. If there is decay, you remove the decay under the rubber dam. Clean out the decay. Then you rebuild the missing walls. You must have 4 intact and sealed pulp chamber walls. Once you have all of that, then and only then you access the canals endodontically. You make your endodontic access, then straight line access. You proceed to create for yourself straight line access into the canals. Identified orifices must be identified. Attention is directed toward preparing the root canal, and only then you start thinking about preparing the root canal. But first, the fundamentals that I told you about, those fundamentals need to be adhered to. If the pulp is vital and bleeding, the chamber is filled brimful with a viscous chelator. And we talked about that yesterday. The most famous of which is RC prep. When the pulp is necrotic, the chamber is irrigated and filled with 5.25% solution of sodium hypochlorite. It doesn't have to be warm sodium hypochlorite. I used to do this. I used to warm up my sodium hypochlorite. Then I realized it wasn't working for me. So you don't have to warm it up. Just use room temperature 5.25% solution of sodium hypochlorite. Don't dilute it. 5.25% right here in the holy book. So is written. Do not put a nitify in a canal before you've scouted those canals. So scouting of canals is very important. And scouting is achieved by using stainless steel, O2 tapered, number 8, number 10, and number 15 hand files. After you've scouted the coronal 2/3, the canal is flushed with 5.25% sodium hypochlorite and pre-enlarged using hand instruments or rotary shaping files. With the coronal 2/3 optimally prepared and filled with irrigant, the apical third is then scouted and information is gathered. Scouter files are used to negotiate the rest of the canal, confirm smooth glide path to the terminus, and establish patency. Then you use your apex locator. If you don't have an apex locator, then you take a PA, working length PA. All right. Now, once you establish your working length, your proper, appropriate working length, then with the root canal negotiated and the anatomy fully appreciated, a decision can be made whether to finish the apical third with hand or rotary instruments. That's why it's important to know how to hand instrument, because you can't put a rotary file in every single canal. In today's reading from the Holy Book of Endodontics, let's talk about medicaments and provisionalization. When one visit, complete endodontic treatment cannot be provided, calcium hydroxide is an intracanal medicament often used between visits. Although its mechanisms of action are not well understood, its inter-appointment attributes have been thoroughly studied. During the subsequent appointment, irrigating with sodium hypochlorite in calcium hydroxide-filled canals has been shown to enhance the removal of intracanal tissue and related irritants. The canals must be filled with calcium hydroxide medication, and one of them is Vitapex or Vitapex. Then the clinician can place a cotton pellet moistened with chlorhexidine into the pulp chamber and seal the access with a durable restoration that prevents microleakage. All right. This is if you buy a pre-mixed syringe of calcium hydroxide. For those who, like me, I have a bottle of calcium hydroxide powder, and my assistant mixes the calcium hydroxide with hypo. So if you mix your calcium hydroxide with hypo, like I do, don't do this step. Don't place a cotton pellet moistened with chlorhexidine. Remember the reaction between chlorhexidine and sodium hypochlorite? You don't want that to happen in the tooth. So what you can do is you can just don't place a cotton pellet. I don't like placing cotton pellets either. So just place a sterile sponge. You don't need this. This step I disagree with. I don't like using cotton pellets in pulp chambers. I've made a video on that. A cotton pellet fiber, if it sticks out, and they usually do, I have a video on that. Go watch that video, and it wicks saliva right into the pulp chamber and contaminate the... Now, as far as placing calcium hydroxide in the canal, you need to be really careful when doing so, especially in cases where the calcium hydroxide is already pre-mixed and comes in a syringe. Usually they come with a long tip to syringe the calcium hydroxide into the canal. You really want to be careful with that, because if you are not careful placing the calcium hydroxide with those types of pre-mixed syringes and tips, then you can literally inject the calcium hydroxide right out of the root of the tooth into the periapical area and cause all kinds of issues, especially if you do so in anatomically sensitive areas. So be really careful with that. Just like irrigating with sodium hypochlorite, you don't want the tip of the needle of the calcium hydroxide syringe to bind. What I would do usually in those cases, when I used to buy those pre-mixed calcium hydroxide syringes with the tips that come with them, I would place the tip mid-root and inject very carefully and slowly until the canal was filled to the brim. Then I would use paper points, and I would gently insert the paper point into the canal, carrying the calcium hydroxide all the way to working length. Of course, you want to measure the paper point so that you know that the paper point goes all the way to your working length. I would do this until I filled the whole canal. What you need to do is you literally need to obturate the canal with calcium hydroxide. It has to be dense. The placement of calcium hydroxide in the canal has to be complete throughout the entire length of the canal and dense. Calcium hydroxide works when it's in contact with either tissue, pulp tissue or remnants of pulp tissue, endotoxins of the bacteria and the bacteria themselves. It's not like you put a little bit of calcium hydroxide and suddenly calcium hydroxide has this magical effect and it can travel by itself and go find bacteria, pulp tissue, remnants of, and endotoxins to get rid of them. Calcium hydroxide has to be in contact with those. So you have to put the calcium hydroxide in the canal, just like how you obturate the canal, densely and to the working length all the way to the canal orifice. That's how you're supposed to fill the canals with calcium hydroxide. Again, calcium hydroxide works when it's in contact with remnants of pulp tissue, bacteria, and endotoxins. It doesn't have magical power that you put a little bit of it in the canal, or you just put a little bit and then you push it and you create a little surface, you create a little line in the canal and think that that's it. Calcium hydroxide doesn't work that way. Calcium hydroxide only works when it's in contact with remnants of pulp tissue, bacteria, and endotoxins. Okay, so make sure your calcium hydroxide is placed densely and all the way to the working length. In today's episode of reading from the Holy Book of Endodontics, let's talk about post-operative instructions. If you're doing a root canal on a patient and you don't give patients post-operative instructions, you've only done half of the job. When practical, teeth that are undergoing endodontic treatment should be taken out of occlusion. Occlusally reduced teeth are generally more comfortable inter-appointment. Post-operative instructions should be given orally, meaning that before you dismiss the patient, you talk to him about the do's and the don'ts, and in case of this and in case of that, and in written format to maximize patient retention and cooperation. Patients should be advised to anticipate soreness to biting pressure for 2 to 3 days and to discontinue chewing on the tooth in question during this period. Generally, mild over-the-counter anti-inflammatory analgesics are excellent and address the transient inflammatory symptoms observed clinically. You can also prescribe stronger anti-inflammatory analgesics. You can prescribe narcotics and even antibiotics when they're needed. Okay, I want to answer this follower's question regarding pulp exposure. Pulp exposure in permanent teeth and as a matter of fact, even in immature teeth in children, adult teeth in children with immature apices, or immature adult tooth in children that are not fully formed? What if you have a pulp exposure because of decay? You're removing decay and you have pulp exposure. So you need to know what decay is. What's in the decay? What's in the decay is microorganisms, bacteria, viruses, fungi, and all their byproducts, toxins. So if you don't have a rubber dam on and you start cleaning out the decay and you're not paying attention, of course, you're just cleaning out the decay, so your burr is contaminated with all the contents of decayed lesion, which are again microorganisms, all kinds of microorganisms, bacteria, fungi, viruses, and their byproducts, and you carry all of that stuff, all of these microorganisms and their byproducts as you're removing them, and you suddenly have pulp exposure. So you carried all of that stuff into the pulp tissue. So the pulp tissue is not sterile anymore. And now you want to cap it? So you inoculated a sterile tissue with all kinds of microorganisms and their byproducts, and then you're going to put something over it and hope that you're going to have dentinal bridge, or you are not needing a root canal. That all comes from the fact that some of you guys don't know your biology, and you don't know really what you're doing. You're just doing it without the scientific knowledge behind it. And that can definitely cause all kinds of problems, not only for you, but also for your patients, because your patients will suffer. And when your patients suffer, they make sure that you suffer in the process. So let's see what the Holy Book of Endodontics tells us about direct pulp capping when there's pulp exposure due to decay. All right, here goes. The ideal treatment for all carious exposures, except those in teeth with incompletely formed roots, might be pulp extirpation and root canal filling. Basically, what it tells you is that the ideal treatment for all carious exposures is a root canal, complete root canal treatment. Nevertheless, there are still indications for direct pulp capping. What are those indications? Sometimes it's economics. Let's say the patient doesn't have the money for the root canal, for the complete root canal therapy. Time. Sometimes you don't have the time, or the patient doesn't have the time for the complete root canal treatment. So basically, what it tells you is that if you do direct pulp capping, in those cases when there's carious exposure, you're just basically buying time. You're buying time. It's not a permanent solution to this patient's problems. This patient very likely will need a complete root canal, but for now, because the fact that the patient can't afford the complete root canal, or you didn't have the time, or the patient didn't have the time, you're just doing something temporary for this patient to just help him out. And sometimes difficulty of achieving root canal filling in certain teeth. Just a few examples, or a few of the reasons clinicians may choose pulp capping over another form of pulp therapy. If pulp capping is considered, clinicians must consider all the factors discussed in this section to determine the prognosis of each case. In the event of failure of direct pulp capping, there is usually the option of endodontic therapy. pulp capping should not be considered for primary carious pulp exposures or for permanent teeth with a history of spontaneous toothache. Radiographic evidence of pulpal or periapical pathosis, calcifications of the pulp chamber or root canals, excessive hemorrhage at the exposure site, or exposures with purulent or serous exudates. So, it's all here. You need to know the science. If you don't know the science, as I said, if you don't know the science, then you're just an amale. You really don't know what you're doing and you're doing it. You're drill and fill. Doctor. You have a doctor before your name, but doctor is someone who knows anatomy, who knows biology, who knows physiology, who knows the sciences behind what they're doing, the reason why they're doing what they're doing.
In today's episode of Reading from the Holy Book of Endodontics, let's talk about the subject at hand, what we've been talking about. We had a question that was asked, good morning, about trauma to a tooth and what happens, what can happen, calcific metamorphosis or pulp canal obliteration. Luxation of teeth as a result of trauma may result in calcific metamorphosis, a condition that can, in a matter of months or years, lead to partial or complete radiographic obliteration of the pulp chamber. The cause of radiographic obliteration is excessive deposition of mineralized tissue resembling cementum or occasionally bone on the dentin walls. Clinically, the crowns of teeth affected by calcific metamorphosis may show a yellowish hue, which means discoloration, compared with adjacent normal teeth. This condition usually occurs in teeth with incomplete root formation. Trauma results in disruption of blood vessels entering the tooth, thus producing pulpal infarction. The wide periapical foramen allows connective tissue from the periodontal ligament to proliferate and replace the infarcted tissue, bringing with it cemento-progenitor and osteoprogenitor cells capable of differentiating into either cementoblasts or osteoblasts or both. See, it's all here. You need to memorize this book. Memorize this book. From cover to cover, like I did. I've read this book from cover to cover so many times. So, I've memorized it. In today's episode of Reading from the Holy Book of Endodontics, I just randomly opened the book. Just randomly for fun, and look, I came to this topic here. Periodontal examination. Competent endodontic treatment. Endodontic treatment begins with adequate diagnosis, adequate diagnostic procedures, as discussed in chapter 1 and 2. An adequate periodontal evaluation must accompany each endodontic diagnosis, which requires a diagnostic radiograph, clinical visualization, evaluation of the periodontal tissues, and probing for periodontal pockets with a calibrated periodontal probe, particularly in furcation areas. Although endodontic treatment may be successful, tooth loss may result from progression of any residual untreated periodontitis. Consequently, periodontal evaluation and prognosis are mandatory, so that the patient and dentist can make an informed and intelligent choice about whether to proceed with endodontics, a combination of periodontal and endodontic treatment, or extraction. Each tooth undergoing endodontic therapy and adjacent teeth should be probed with a calibrated periodontal instrument to obtain 6 measurements per tooth. Pockets of 4 millimeter or greater should be recorded on the patient's chart. If no pocket exists, WNL within normal limits or a similar abbreviation should be noted. Mobility should also be charted and designated class 1, 2, or 3. Gingival recession, furcations, and mucogingival deficiencies should also be recorded. A dentist who treats with endodontic success but ignores loss of periodontal attachment may misdiagnose or fail to appreciate the risk of failure because of poor periodontal prognosis. The endodontic treating dentist should not assume that an adequate periodontal evaluation has been performed by another dentist, even the referring dentist. Instead, an independent periodontal evaluation should be done with a calibrated periodontal probe. If clinically significant periodontal disease is present, the endodontic treating dentist should consult with the restorative dentist to determine whether the periodontal disease will be properly treated or referred to a periodontist in conjunction with endodontic treatment. The patient should be advised of any compromise of the endodontically treated tooth's periodontal status to comply with required informed consent disclosures.
You couldn't find how to avoid an hypo accident in the Pathways of the Pulp textbook? All right, let's see. Pathways of the Pulp textbook. Let's go to the back. Get rid of my notes. Let's go to index. Let's go to H. CFG, H. Oh, what is this? Hypochlorite accident. Pages 68 through 70. All right, let's go to 68 through 70. All right, let's chew the food and put it in your mouth. All right, so 68, 61, 63, 65, 67, 68. All right, hypochlorite accident. Definition, causes, management. By the way, I've already made a video on this. I'm and posted it. All right. Oh, what is this? Prevention. All right, how to prevent it. Crisis is completely avoidable. All right, how to prevent it. All right, here it goes. How to prevent it. Irrigation needle should be bent at the center to confine the tip of the needle to higher levels in the root canal and to facilitate direct access to all teeth regardless of angulation. The needle should never be placed so deeply into the canal that it binds against the walls. All right. 3, the needle should be oscillated in and out of the canal to ensure that the tip is free to express irrigant without resistance. All right. 4, the irrigant should be expressed slowly and gently. All right. Irrigation should be stopped if the needle jams or if there is any detectable resistance on pressing against the plunger of the syringe. The hub of the needle should be checked for a tight fit to prevent inadvertent separation and accidental exposure of the irrigant to the patient's eyes, and so forth. All right, so here it is. Oh, look. Remember what I was telling you guys about yesterday? The art and science of endodontics. The art and science of endodontics. So endodontics is not about just having pretty white lines on an x-ray. There is a science to it also. And the science is in this book. It's all here. So you just need to read it. So it's not everything endo related is in this book. You do endo, but you haven't read this book, I don't know what to tell you. You should have memorized this book. If you do endo, Pathways of the Pulp is the Bible, the Quran, the Torah of endodontics. You must know this book from cover to cover. You must know it. And then, of course, you must know your anatomy as well. And I have all kinds of endo books, plus of course, I have my anatomy books here. All right, that I reference sometimes if I need to see something. I immediately go to my anatomy books, and of course, the Holy Book of Endodontics. And many people also ask me, how can I be better at endo? How can I get better at endo? And I keep telling you guys, the most important thing is for you guys to practice. You can't just sit on your butt and expect your endo level to go up, to gain knowledge. You must practice on extracted teeth. If you want to get better at anything, basketball, football, soccer, baseball, volleyball, at anything, biking. If you want to get good at anything, you practice, right? Why is endo any different? Practice on extracted teeth. You must practice on hundreds and hundreds of extracted teeth, any opportunity you get. Another question that I get asked on a regular basis is how to avoid breaking or separating files in the canals, how to avoid that. And again, I've made many clinical videos, and I've gone over this topic many times before, but here's another video again. So the most important thing is to first, before you put a NiTi file in a canal, you must scout the canal. It's called scouting the canals, or canals, okay? And the way scouting works is that you use your stainless steel K file and your fingers, and you go into the canal with that file to get a feel for the canal, to get a feel for the complexities of the canal, to get a feel for the curvature of the canal, to learn from the feedback that you get through the file and on your fingers, to kind of figure out the complexities of the canal, all right? And then crown down is the most important thing. Before you put a NiTi file in a canal, you need to open the canal up. You need to create a glide path, all right? Glide path is very important. If you don't create a glide path to your working length, but you go ahead and put a NiTi file in the canal, if you don't scout the canal, if you don't create a predictable glide path, at least to a size number 15 file, stainless steel K file, at least to a number 15. I usually sometimes go to 20 or 25 before I put a NiTi file in the canal. Then you're going to break your files. The NiTi files will break. So scouting the canals, creating a glide path, a predictable glide path. I always say you must own the canal. Owning the canal, meaning that you put a number 15 file, you throw it like a dart, and it should go into the canal and down to the working length. It should be that easy for a number 15 file to go into your working length. That's a predictable glide path. Once you create that predictable glide path, once you have owned the canal, once you know the complexities of the canal by using a scouting file to go in and figure out the curvature of the canal and what have you, only then you should put a NiTi file into a canal. That's how you don't break NiTi files. Oh, hi. Didn't know you were there. I'm just reading my daily holy book reading. And today I was a little bit triggered by one of my followers who was asking about the fact that he had a patient with hepatitis. He had a patient with hepatitis, and he was wondering what he needed to do differently with this patient specifically. That kind of triggered me a little bit because, as I always say, when you read the holy book of endodontics from cover to cover, and not just read it, but understand it and apply it, then you shouldn't be really asking these questions, especially since you are already a doctor, which means that you have completed a very rigorous program and graduated as a doctor. Page 163 of the Pathways of the Pulp, my edition, the edition that I have, which is the 8th edition, which is the old edition. Under barrier techniques, it says, the Occupational Safety and Health Administration, OSHA, requires that dentists follow infection control guidelines established by the Centers for Disease Control and Prevention, CDC. These guidelines define the use of universal precautions to prevent cross-contamination while treating patients. Universal precautions, meaning that you assume every single patient, the worst infection and transmissible diseases. That's what the universal precautions tell you. You treat every single patient as though they have the most transmissible and infectious diseases that exist to humankind. That's the universal precautions. When you assume every single patient that you treat has the most transmissible and infectious diseases, then you just follow the guidelines, the universal precautions, which include sterilization, barrier techniques, and then there are, of course, different methods of sterilization that this book goes through, such as steam under pressure. See, it's all here. It's all in this book. So you don't have a protocol for a healthy person, a healthy patient. You don't have a different protocol for a person with cold. You don't have a protocol for a patient with hepatitis. You don't have a protocol for a patient with HIV. They're not different. We don't have different protocols for different groups of people. It's universal precautions. That means you assume everybody has the most infectious diseases, everybody who comes into your office, and then you follow the universal precautions. Universal precautions has been established because how do you know the person who marks everything on their in their medical history, everything, you have this, no, how do you know they're being truthful? That's why we established the universal precautions. And sometimes the patient is truthful. They don't even know that they have an infectious and transmissible disease. That's why we have the universal precautions. We just have to assume everybody has the most infectious diseases that are out there. So for you to ask me what should I do differently when a patient comes in and they have hepatitis, it tells me that you just don't understand the basics of the science of dentistry and medicine. It really triggers me and bothers me. You're a doctor. If there was average Joe asked me this question, I would understand. I would say, fine, I can explain this to you. But as a doctor, you graduated from dental school and you have a degree, a doctorate degree, a doctoral degree. That really bothers me that you don't understand the basics. So please, for the sake of your patients, read this book and understand it. I don't know how many times I can tell you this. These are the basics. But they're fundamentals. So I can't be teaching you the ABCs of dentistry and medicine. Page 170, my edition, Pathways of the Pulp. This is an old edition. But the fundamentals have stayed the same. If you're buying this book, make sure you buy the latest edition. But in my edition, page 170, take a look. Sterilization of gutta percha. The sterilization of gutta percha cones is of importance in endodontic practice because this material may come in intimate contact with periapical tissue during obturation. Immersing gutta percha cones in 5.25% sodium hypochlorite, that is full strength household bleach, for 1 minute is very effective in killing vegetative microorganisms and spore forms. Gutta percha can also be decontaminated by immersing cones for 1 minute in 1% sodium hypochlorite or for 5 minutes in 0.5% sodium hypochlorite. See, it doesn't talk about crystalline formation on the surface of the gutta percha in the atomic level or anything like that. It bothers me that some of you guys are hung up on what about this study that they look at the surface of the gutta percha at the atomic level using a microscope, using an electron microscope, microscopic level, and found crystalline formation on the surface of the gutta percha. Come on, man.